So just a brief kind of history of me and my practice. I started in Northern Ohio in a private practice that was just a little too small. I moved across Ohio to Akron, Ohio. Got to see LeBron James play in high school, which was exciting. I did a fibroid embolization on his aunt, actually, which was really cool. In that practice at Akron General, we actually had the biggest vertebroplasty practice in Ohio other than Riverside Hospital in Columbus. All vertebroplasty, we had bought into that a long time ago and just saw great outcomes. Then moved to Salt Lake City, where I was at the University of Utah in the Huntsman Cancer Center, which is an NCCN cancer center, for 6 years. Very bizarre politics there, very dominated by spine surgeons who, I just don't think they read the literature, honestly. So very, very hard to do vertebral augmentation there because of political reasons. Slowly it's grown, it's moved into the pain management realm. There's a great guy there who I know well, who's trying to push things through the whole kind of pain management side of things. And so for 6 years, I didn't do a lot of vertebroplasty or kyphoplasty. I left academics for the same reason why most people leave academics, for basically political reasons, frustrations with chairmans and that kind of stuff. And moved across town to St. Mark's and joined a big private practice there, where, again, really had the largest kyphoplasty practice in kind of the whole Intermountain West area. And the person I joined was really set on balloon kyphoplasty. I had been frustrated by my inability to control very non-viscous cement with vertebroplasty. So when I, stumbled upon the use of balloons and highly viscous cement, seemed like a great thing. We had great outcomes. And then starting a few years ago, with the advent of DFINE's devices, it just seemed like the right thing to try. It seems like the right combination of vertebroplasty and kyphoplasty. And if you're not using it, I'd really encourage you to just start trying to use it and see what you think in your hands. See what you think. I think it's really kind of an evolution of vertebral augmentation. So the objectives for today are to talk about the perceptions of vertebral augmentation. That changed dramatically in 2009, much to everyone's chagrin, with a publication of 2 trials. What is the opportunity? And then we're going to review the data and clinical evidence, talk about technology and case examples pretty quickly. So is everyone here treating vertebral compression fractures? Just raise your hand if you are treating VCFs. So there are a few hands that didn't go up. I assume you're here and you want to treat those. So those that are treating, what are your local problems? What are your hurdles for having a bigger practice? Anybody willing to talk about that? Speak up, anything? Yeah.
The biggest thing is lack of visibility of what we do. And I've come to the conclusion, we have the biggest vertebroplasty practice in the southern half of the state, probably, but nobody knows the genius that started it all. They don't know that he's done 1,000 cases, that he's had little old ladies up and out of bed.
Yeah.
You need your own web presence. You need a website that has technical images and anecdotes.
Yeah, that's great. Anybody else? Okay, great. I think that's exactly right. In 2009, again, things changed, but we also just suffer from who we are. We're interventional radiologists. We aren't. It's hard for us to get out there and really become known. And I think there's some key strategies that you can use to get other partners involved so that you do have a bigger presence. It's not a part of my talk, but it's something I'd love to talk about later or between sessions or something. Or at the end, maybe remind me, and I'll just kind of quickly tell you what we've tried to do to overcome some of that. So what are the perceptions? First of all, vertebral it doesn't work. Vertebroplasty is just, it's no better than sham. That's what we hear all the time. Another perception, it costs way too much. And boy, now you're getting into kyphoplasty and inflating balloons, and the costs just skyrocket. And why? Why are you doing this? fractures are actually decreasing in number. I don't know where that comes from, but I'm hearing that. I mean, that's absurd. But anyways, I'm hearing it. And then all cement's the same. The goal here is just get access with your needle, get cement in, you're done, turn your brain off, easiest thing you do, don't think about it, and you're done. You know, that's a really common thing I hear from interventional radiologists. That, you know, this is an overthinking if you try to spare balloon and create preferential pathways. You're overthinking it. I disagree. So reality, hundreds and hundreds of papers talking about how vertebroplasty does work. Augmentation does work. There is some great new data through Medicare where mortality actually goes down if you treat. If you aren't treating these people, they die. Back braces kill. And costs increase. You're really sticking it to your hospital if you don't treat these people. Fractures are a huge societal problem. And actually, cement viscosity and radiopacity are really variable, and it's really an important concept. I think Bob's demonstration of that plunger, when I saw that, I thought that was a great representation of low viscosity cement versus high viscosity cement, finding an exit path through that cortical margin and vertebral body, and how with low viscosity cement, it's all dumping into, you know, the inferior vena cava or the periosseous structures. High viscosity raises that plunger. That's real physics. So clinical overview, or of clinical data. So the value and the utilization of clinical evidence. There were certainly reduced referrals since the two articles in 2009 in the New England Journal of Medicine. There is a large clinical incidence of painful VCFs. The consequences of delaying treatment are very well documented, and literally it's death and destruction. And that sounds like I'm being theatrical. It's not. Read the literature and you will see if you don't treat these people, they develop bed sores. The SIR white paper on their response to the 2009 articles does a beautiful description and discussion of the hazards of bed rest. Bed rest kills people. It's really bad. So you can hang your hat on this. You delay treatment and people are dying because you didn't intervene. You got to understand the clinical data. You got to read those papers. Take notes. You know, put them in your iPhones. You can pull them out on the phone as you're talking to referring doctors and really refer to this stuff. But you know, you've got to be able to differentiate the studies and really look at things critically. And you have got to educate people constantly. You can't tell your ER doc once. You've got to go back and back and back to your referral doctors and keep educating them. You got to educate your own IR peers. And in fact, I think some of my biggest hurdles are my DRs. The neuro guys who love to read the spine MRs, who don't do intervention. They never have. They did a non-interventional neuro fellowship. They feel like they're real experts on this. And I have heard them badmouth intervention and augmentation repeatedly. So I have to fight my own DRs and explain to them how the Kalmus and Buckbinder, studies were really bad studies. That's one of my biggest hurdles. So the number got deleted there, but it's millions are the number of Americans for which osteoporosis is a major health problem. 900,000 spine fractures. They exceed the hip and wrist fractures. 150,000 people are hospitalized due to pain and need medical management because of their fractures. If you don't treat these folks, you're talking about an average length of stay of around 8 days. And again, billions of dollars are spent dealing with these fractures and the problems associated with them. The main causes are going to be either osteoporosis or metastases. Again, osteoporosis is very common. Most are females, 80%. And it's going to become a bigger and bigger problem as osteoporosis increases, obesity increases, kind of the sedentary American, increases. Again, hazards of bed rest, kind of. Degenerative disease weakens bone over time. Again, many fragility fractures, 900,000 are in the spine. We all know kind of the causes of metastatic disease to the spine: breast, lung, kidney, prostate, multiple myeloma. So what are the risk factors? Certainly a prior fracture is maybe the biggest risk factor. Bone marrow density, obviously key. Age, the older you get, the higher the risk. Sex, again, mostly in women. A fracture deformity changes the biomechanics and predisposes to more fractures. And if you're on some type of medication like steroids, that can thin your bones, cause osteoporosis, and you can have a big increase in risk. And there are others. This is a really interesting diagram. Basically, you're breaking down people with high density, medium density, and low bone marrow density, and then if they've had no fractures, 1 fracture, or 2 fracture. If you've got somebody with a DEXA scan of a T-score like -3.5, and they've had 2 fractures, their chance of having yet another fracture, 75-time relative risk. So 1 fracture predicts other fractures. And then again, your DEXA score kind of variation. So kind of averaging that, I tell people that if they've had, if they've had 1 fracture, they have a 5-fold risk of having another fracture. If they've had 2 fractures, they're going to have a 12-fold risk of having another fracture. So if you have a hip fracture, that's bad. Your relative risk of dying is 6.68 times. However, if you have a spine fracture, your risk of dying is even higher. These people have kind of worse disease. People say, it's more debilitating. A hip fracture you can repair with surgery. All those things kind of affect this. If you have a patient with a spine fracture, they are a sick person and in need of help. That's what that slide kind of means to me. So VCFs are underdiagnosed and they're undertreated. 2/3 of all fractures go undiagnosed. Patients just kind of tell you it hurts everywhere. Other comorbidities take precedence. People just aren't looking for them. If you're old and you have back pain, yeah, well, you're supposed to have back pain. You're old. 42% of symptomatic fractures no findings on plain film x-rays. You've got to get an MRI. Again, I think this, by our DRs, is just dramatically underrepresented. I don't think they remember how bad plain films are when you're looking for fractures. Moderate to severe fractures are reported only 50% of the time. You've got a 2 view of the chest, you're looking at the heart, you're looking for lung cancer, you're looking for pneumonia, and you kind of forget to really comment on the spine. Or you see a fracture on an 85-year-old, some vertebral compression, wedging of T8, and again, that's almost normal. Your eye just doesn't even catch it. And back pain isn't chest pain, so that's kind of a hard relationship sometimes to make when you're just looking at plain films. And then this is crazy. Only 20% of people that have VCFs related to osteoporosis receive any kind of bone marrow testing or treatment. Again, I think they're kind of blown off by family practice docs. You're old, your bones are thin, yeah. So that's normal. Why do I need to test it? I'm going to give you calcium and vitamin D anyways, maybe. So the diagnosis really isn't confirmed. So how do you diagnose these folks? Well, they're older, typically. Though 50 isn't seeming that old to me anymore. Sudden onset of back pain. Again, very often, nobody will report trauma. They laughed too hard. They sat down on the toilet too hard. It's amazing how often people will say, I didn't fall, I'm fine. So when their family asks, Mom, your back hurts, did you fall? And she says, no, nobody's thinking about a fracture. Physical exam, you're going to usually have pain and tenderness over the spinous process. And the key, which just kills me, is like pain with movement. Someone's sitting there or laying there in bed and you ask them if they're in pain. And they say, no, I'm not in pain. And the PA leaves the room and says, no pain. Then you go back and say, well, what if you move? What if you twist or you stand up? And they go, oh my God, yeah, that's 10 out of 10. I can't do that. But sitting right here, not moving, I'm not in pain. So you actually have to ask 6 different times, what about movement? What about if you twist? Go ahead and get up from the chair and walk across a room. And that's often when you finally come up with that history of pain. Or again, they say, yeah, my shoulder hurts, my knee hurts, my ankle hurts. And then you have to hone them in on their back. And they really ask about that. A lateral spine radiograph, that's helpful for sure. Quick and easy, cheap. But you gotta do MR. And even people in our practice where we have this big practice, it's amazing how many times somebody will maybe have had a kyphoplasty, they come back with back pain a few weeks later, we get the plain films, we see 1 new fracture, and no one gets the MR because we know there's a new fracture, we know we're going to treat them, but the MR will show that there are actually maybe 2 new fractures or 3 new fractures. So you've got to get an MR every time. It seems at times like you're wasting money, but every 6th time you do that, you'll see that other fracture. And if you're only treating one of the two, you're not going to have good outcomes. So get an MR every time. So value of MR, this is great. You've got this wedge vertebral body here. You do the MR, and that's actually an old fracture. This is the new fracture with the edema on T1 and the cleft. So you see that all the time. You've got to look for discs. You've got to look for retropulsion. Maybe it's a tumor. You're trying to figure out the age. It's funny, everybody kind of says, look at your stir images, they're bright. Honestly, I think more often the T1 weighted images are more helpful. They actually show you the fracture plane, looking for metastatic disease. 3-phase bone scan with SPECT. This just freaks out our nuclear medicine techs. They hate this, but it's really the right way to order a bone SPECT if you are trying to figure out whether or not you're going to intervene. So it's not just a bone scan with SPECT, but it's actually a 3-phase bone scan with SPECT. And it is the best way, if you can't use MR, to figure out what's going on. Again, you're going to see if it's acute, you're going to see increased activity on the first phase that persists basically all the way through. If it's an old fracture, and fractures can stay hot for a really long time, you're not going to see that increased activity on the early arterial and kind of blood pool phase. And then we've got into this problem a couple times because we have kind of a pathway that goes right from the ER to our service for kind of pretty immediate treatment of fractures in old folks who you really can't safely send home. If someone's 80, the teaching in radiology residency was it takes that number of hours for the bone scan to become positive. So if you're 80, you need 80 hours since the fracture until the bone scan will become positive. And we've had a couple false negatives where we quickly get that 3-phase bone scan with SPECT on an 85-year-old. It's normal. You have plain film evidence that that there's at least one new fracture there, and the bone scan is normal. You have to wait and repeat it. So we've actually kind of done the workup too quickly, which is interesting. So don't forget about that. Fluoroscopic physical exam, I think, is really helpful. It gets you out of a jam a lot. You may see, a localization or, kind of a grouping of 2 fractures here and 1 up there. And if you can localize it to this area, maybe you treat those 2 because they both look fractured and you leave that one alone. And you've kind of maybe primed your pump for knowing that if their pain partially improves, you get them back in to maybe treat that other level, but maybe not. Maybe this really is the cause of their pain. So I do this a lot to help kind of figure out exactly what levels I'm going to treat. I would not use that exam, though, to say, oh, it's definitely T12 and not L1. You just can't differentiate one vertebral body from its contiguous vertebral body, but I would treat both of those. CT, done a lot through the ER. I really don't like it. I mean, it's better than nothing, and honestly, that's like how I sum up CT. It's better than nothing. You'll see the fracture, but again, you won't see the cortical step off in the adjacent vertebral bodies, and that happens all the time. This is just like a super good plain film. That's what CT is, So better than nothing. Helpful if you combine it with a bone scan, maybe. So you're getting kind of spec CT. Do it if you have to. Again, MR is the key. So research data. There are actually 300 to 400 articles that have been published on vertebroplasty, talking about the technical aspects. But if you're looking at clinical data, there are 100 to 200 articles that have been published on vertebroplasty looking at the clinical outcomes. And it varies from just a simple case study all the way to prospective randomized controlled trials. And there are some additional trials underway, and there are even other trials since this slide has really been created that are relevant and speak to the benefits of vertebral augmentation. And virtually every paper is positive and talks about how you get significant pain relief and improved disability scores if you're doing vertebral augmentation. So huge body of evidence saying that what we're doing works. This is a great paper. It's now a few years old, but it's just something you've got to get. You've got to highlight. You've got to just burn into your memory. It is a great discussion of kind of why we do what we do. This is the Kalmus paper from 2009. You got to learn and read about this so you know kind of what to say to people who cite it. And this is the Vertos 2 trial. Again, great evidence speaking to the benefits of vertebral augmentation. So I'm just going to digress for just a second, but I think this is really key. Is the importance of words. We're almost all probably radiologists in here, not everybody, but we are wordsmiths, or so we think. And I think it's really important. I don't use the word conservative management. I think it's incorrect. What I use is, if someone doesn't undergo vertebral augmentation, they're having non-operative management. So conservative equals non-operative. Again, I don't like the term conservative. So both of those terms versus operative management. And it's important for your referrers to understand the difference here, and for all of us to really think about what conservative management means. In medical school and residencies, we're taught that conservative management is really good. First do no harm, everybody likes to say. If you're not sure that what you're going to do is going to help, then it's okay to not do it, right? If you're not sure it's going to help, then maybe you shouldn't do it. It's passive. It's the default. It's not really a choice. You just kind of, first do no harm, which is a great way to kind of get out of something. Somehow we assume that conservative management is good and that it shows you're really thoughtful and you're not just churning and rushing in to do a procedure that, helps your W-2 and pays for your kid's college education. You're not subjecting anybody to unnecessary risks, and you can kind of stand there and say, first do no harm, I better not treat. We're not surgeons who just rush in and do stuff. We're smart radiologists and we're scientists. And conservative management is always a really reasonable option. I think that's totally wrong. So, there are a lot of things we don't manage conservatively. You don't manage a perforated viscus and say, well, first do no harm, free air, abscess, whatever. We all know some surgeons who kind of do that, and their colleagues say, you're not a surgeon, go into endocrinology, please, You don't manage an early stroke by saying, well, it's just the way it is. A hemorrhage, you don't manage that way. Sepsis, you don't just sit back and say, well, I could give you antibiotics or drain your abscess, but, hey. Infected gallbladder, you drain that right away. You don't do this with acute painful vertebral compression fractures in the elderly. You just don't do it. Medicare cost data. So this is really compelling stuff. You look at Medicare's own data. Improved survival when you compare it to conservative management. Further improved survival if you're really doing kyphoplasty compared to vertebroplasty. You're decreasing overall costs. You're dramatically changing the risk of complications from bed rest and immobilization. These are really, really relevant conclusions. Narcotics, bed rest, and back braces kill. That, again, really kind of theatrical statement, but it's really true if you look at this data. You throw someone in a back brace, give them narcotics, and lay in bed for 6 weeks, a huge number of those folks die because of that choice you made not to intervene. Kyphoplasty will save the hospital money. You can show your CFO this data, and they will run right out and buy you navigational osteotomes, or maybe even balloons. MedPAR, same thing. Patients managed non-operatively more likely to die during that hospitalization. Increased 3-year survival rate, shorter hospital stay, least likely to have pneumonia, decubitus ulcers. Just it goes on and on and on if you look at the data regarding bed rest. Increased mortality in people who are not operated on. So operative versus non-operative management, use non-operative instead of conservative. If someone wants to follow conservative management, then the onus is on them. They have to take the responsibility that their choice is leading to bad outcomes, and it will lead to bad outcomes. So we choose to operate or intervene because it is the right thing to do. There's data to support it. You are actually prolonging survival. Forget ablating their tumor and overall survival and stuff like that, oncologically speaking. By treating their fracture, you will prolong their survival. You dramatically improve their quality of life. It saves the hospital money. Also, non-operative and conservative management is actively, not passively, causing the patient harm. By choosing conservative non-operative management, you are knowingly and actively injuring a patient. and I don't like to do that. So it's not just a first do no harm. So anyways, back on track. But I think that's a key point to make to your referring doctors. When they say, why are you doing that? You just take the ream of paperwork from the trials and say, I'm doing this because if I don't do it, I'm going to kill your patient. Maybe. So anyways, under treatment based on basically misinterpretation of the vertebroplasty and vertebral augmentation evidence. These 2009 articles were a huge setback. They're in the New England Journal of Medicine, which, I don't know, I was taught in my training to basically never read because there's nothing, it's kind of like JAMA. There's nothing very helpful in that ever. But they love to just dog on device-related trials. These were prospective randomized controlled trials. You got to give them credit for trying that. They were compared to sham procedures. That's really challenging to do. But there are just huge, huge problems with that data. So basically, the conclusions were there was no statistically significant difference, even though there was a huge trend to support the vertebroplasty. It was one patient short of meeting statistical significance. If one patient had done better with vertebroplasty, or one patient had done less well with the sham, it would have met statistical significance. Other problems: the sham procedure was actually a lidocaine injection, like right by the facets. I don't know. I'd see someone maybe getting better if you're pounding 20 cc's of lidocaine right by a facet. The sham is not standard of care conservative management. Huge pre-test selection bias. Again, you look at that position paper from Sir, and it just rips these things apart and gives you 10 really good reasons why the studies were bad. 2 articles came out in Lancet showing that there was a statistically significant clinical difference, and that vertebroplasty and kyphoplasty, again, compared to standard of care non-operative management, and the minimally invasive procedures resulted in near and long-term improvement, and they showed cost effectiveness. So even if you just look at 2009 data, you've got 2 negatives and 2 positives, and that's ignoring the other couple hundred articles out there that support augmentation. So the Kalmus and Buckbinder trials, those are 2 different trials, both multi-center randomized, sham procedure. Patients were blinded. They looked at tons of old fractures. The Kalmus study, they didn't do MRIs on everybody, so they were treating tons of people with old healed fractures, taking people with back pain scores that were really quite low. I wouldn't treat somebody with a 3. Follow-up wasn't that great. Again, huge problems accruing, which by definition means there's a big selection bias. And then again, vertebroplasty was 1 patient short of actually being significantly, being a positive study. There was a huge crossover from the people who weren't treated, or who were treated with sham, huge crossover into the vertebroplasty group. So, I mean, that's not placebo. Only 12% crossed back over. The Free and Vertos trials, the 2 Lancet articles, again, just kind of typical. You'll see this constantly if you look at the literature. Major support for vertebral augmentation. So this is a consensus article. Again, you've just got to print it and know it. It's really great, and it's 4 pages long, something like that. So what do you need to tell your referring doctors? First of all, the key is that if you're gonna, what does the Kalmus article teach you? If you do your procedure really badly, you'll have bad outcomes. But more importantly is, how do you pick your patients? You've got to do MRI. You've got to know that these fractures are acute and that they're painful. You can't treat people with a 3 out of 10 pain that has facet arthropathy with vertebral augmentation. I mean, it's normal logical stuff. You would never make that mistake. So you've got to pick your patients well. You've got to know that their pain was acute. You've got to get people with pain scores, 6 to 10. You've got to do a physical exam and push on the spinous process. You've got to verify it with MR or bone scan and CT. And if you do that, your patients will do well. The rationale for patient selection, again, is that you are stabilizing their fracture, you're getting them immediate pain relief, and you're able to avoid the hazards of bed rest, plus narcotics, and all the comorbidities that go along with it. And then, maybe you can restore height, change some of the biomechanical stresses, and help avoid the next fracture. And there's some real data that says, even though you don't get huge changes in height restoration and angle correction, you get some, and even those few degrees can translate into to long-term benefit. So these are the kind of classic criterion about why you'd intervene. People are on narcotics, their pain is unrelieved substantially, and so you intervene to control pain. Maybe they have decreased mobility and you're helping them with that. Their activities of daily living are being affected. You've got radiographic evidence of fracture. You've got pain localized to that area on physical exam, and you don't have other cord compression, things like that. Where it's moving, though, is to the recognition that just simply getting them up early is key. Early ambulation and rehab, that's absolutely key. You're going to help your hospital. You're decreasing that hospitalization period, and you're going to change the future. You're going to prevent further injury and morbidity by dropping those narcotics. So at least in Utah, for us to get renew our state license, all providers are forced to do about a 2-hour CME course on narcotics and how you prescribe them and the hazards of narcotic overuse. And I think the chart I'm talking about here, it's either national data or Utah data, but there are now more deaths related to narcotic overdose, let's just say in Utah, than car accidents. And the curves crossed a few years ago, and there's now actually quite a separation. So at least in Utah, there is a huge problem with narcotics, and anything we can do to drop that use is going to pay off in a huge way. Again, #1 cause of death in Utah. So use that argument with your family practice docs. So why wait? Well, this is interesting. Here's January 2003. Month later, you go from 10%, 20% loss of height down to a vertebra plana. I don't know what that shape is. It's beyond a vertebra plana. So conservative versus non-operative management, or conservative or non-operative management, pain medications, back breaks, bed rest, physical therapy, and go ahead and build their, have them get their plot in the cemetery. That's where they're headed. Open surgery, 3-column instability, send them to your surgeon. Major cord compression, a gibbous kind of deformity, don't deal with that, get that to a surgeon. Treatment options for minimally invasive operative procedures, vertebroplasty, balloon kyphoplasty, or the targeted vertebral augmentation, or kind of the stability defined type of thing. So this is what I really think is going on. I think, we started with kind of on the left is the major spine surgery or medical management. There was a progression to minimally invasive treatment with vertebroplasty. Excellent procedure, but maybe it could be better. Balloon kyphoplasty, I think, was a step forward and is a little better than vertebroplasty. And then I think the real next step in this whole evolution are to these advanced augmentation options, whatever that means. So vertebroplasty, we all know what it is, a little bit smaller needle put through the pedicle or next to the pedicle into the vertebral body. You inject bone cement that is not all that viscous, and you push it in under kind of meticulous fluoroscopy to make sure it's staying in the vertebral body, going to the fracture line and not going out of the vertebral body. It requires a lot of fluoroscopy to really watch that stuff flow in. You are fluoroing a lot when you do vertebroplasty if you really want to keep it in the vertebral body. And you're really relying on just pressure gradients and hoping. Not much control in vertebroplasty. I think a step forward is balloon kyphoplasty. So vertebroplasty almost always done under conscious sedation. We do all of our balloon kyphoplasty under conscious sedation. Maybe there's some benefits in some people to use GA. Certainly if they have anesthetic risks, once every 6 months we'll do it under GA, but almost always it's under just conscious sedation. You're inflating the balloon, that creates a cavity, so you can use a more viscous cement, which will extravasate less frequently. You can lift the vertebral body some, not a huge amount, but again, maybe a little bit is enough. The thing that kind of bums me out is you're putting in this huge bolus of cement. You're creating kind of a ball bearing or a fulcrum, and if you don't get good interdigitation, you may be harming this person and actually causing fractures at adjacent levels. It's almost always bipedicular, and your radiation exposure is higher. So I think the next step forward really is this targeted type of vertebral augmentation. You can articulate the osteotomes and create these preferential pathways to where you think the cement needs to go. And if you're dealing with a superior end plate fracture, and you come in at a slightly bad angle and you inflate a balloon way down here, and this is your fracture, that's silly. In IR, we have tools, that's what we do. We pick the right tool for the right job. And, if you came at this angle and you're trying to get up the superior end plate, you put in that navigational osteotome, and you can create some nice pathways right up to the superior end plate. So this ability to control and put the cement where you kind of want to put it, I think is really relevant. Again, Bob kind of talked on this. These principles I think are key. You can control where you put it. You've got a higher viscosity cement. What I love is this thin cement that you then heat as you put it in, so you've got long working time, but then you create a very viscous cement basically as it exits the device. And again, that gives you kind of the ability to control what you're doing with the viscosity. And I think that's helpful in some cases. So non-operative care. This is a study looking at non-operative care versus targeted vertebral augmentation. And this is median improvement. So after 6 weeks of conservative care, there was really no change in the VAS score, essentially no change in the disability index. 3 to 4 days after having the targeted VA, boy, 5-point change in pain score, 30% change in the disability index, and that actually continued out to 6 weeks. This is comparing kind of the stability targeted vertebral augmentation to balloon kyphoplasty. Fair number of people. I think very similar outcomes here. Maybe a little bit better for TVA. I think this is kind of the key. Unipedicular, pretty quick, longer procedure here. That's going to translate to fluoro time too. And then again, the difference in extravasation. I think that, again, in some patients is going to be relevant. Often it's not, but in some patients it will. In osteolytic, that was osteoporotic fractures. These are osteolytic compression fractures. Again, big drop in the VAS score, big improvement in the disability index after RFTVA. This is in multiple myeloma. Same type of thing. You're shifting the VAS scores early on from being in this 8 to 10 range down here into this 2 to 3 range. And medication use, again, drops dramatically. So this is a case from Sonny Bagla, bipedicular access. There he is going across the midline with the navigational osteotome. And that's the first fill. That's your first image from putting in the cement, going right through that preferential pathway that was created, right over the other needle. Tiny bit maybe of extravasation here, but look at that vertebral body filling. That's just amazing. Probably the best filling I've ever seen. That's the lateral. Kind of tough to see it. That's before and after. You're not going to get that every time, but that type of diffuse interdigitating cement, you will never see that with a balloon kyphoplasty. So here's a patient, 81-year-old female with osteoporosis, and she was really worried about osteoporosis, so she tried to drink a lot of milk. That was her approach. And it worked for 81 years until she had a ground level fall and developed a 9 out of 10 back pain. She was treated by her doc with a back brace, Percocet, and bed rest for 2 weeks. Her pain just, I think, was bad enough, or she was just a tough old bird who went back to her doc and said, I'm not getting better. For some reason, they got an MR, and that's great. They found an acute T11 compression fracture. At least when I work, I'm doing so much more stability than I am balloon kyphoplasty that we have a brand new tech, and he had never seen a balloon kyphoplasty. So I decided to treat her with balloon kyphoplasty, and I did that, and she did really well. She went home just a few hours later, and she felt so good that she went in to go to the bathroom by herself. She kind of slipped and fell a little bit onto the toilet seat, fell maybe 7-8 inches, and immediately had new 9 out of 10 pain after being almost pain-free after the balloon kyphoplasty. So just a day or so later, she called us. We got plain films. This is the balloon kyphoplasty level. You can see the big boluses of cement sitting there with, some interdigitation. And here's the new fracture. Initially, my partner said, okay, great, yeah, schedule her for kyphoplasty. We don't need an MR. So I disagree with that. We did get an MR. Now, in this case, it didn't help. But believe me, the next time we do that, it will help. So here, well, actually, that's a mouse arrow pointing to the superior end plate fracture. And again, you can, boy, that's really grainy. Here's a cleft on the T1 images near the superior end plate of L1. So this is access. This is just kind of a quick, important thing. As you get to the pedicle vertebral body junction, you still need to be lateral to the medial cortical margin there. And now we've actually penetrated in the vertebral body, and so we're beyond the medial cortical margin. And again, good example of what you can do with this navigational osteotome, kind of went down. So these images are paired kind of over, down, and across, over, down, and across. Actually, I thought there was there was another slide in there that I guess we took out that showed, again, up to the superior end plate in the midline, and then came over laterally up to the superior end plate, which is, again, where the fracture is. And then we put in the cement. Really nice interdigitation. This was unipedicular, entering on her left. And I think that was a great outcome. She did great. Again, this is the balloon kyphoplasty appearance. And this is a great BKP appearance, I think. But again, really, are there hazards involved in that big cementoma in there? I don't know. Again, if you look at the physics of it, somebody would argue that, yeah, there is, that you're just not supporting the vertebral body evenly. So follow-up, after the stability procedure the next day, her pain score dropped from a 9 to a 2. She stopped all of her narcotics. She actually went to Costco, church, and her granddaughter's basketball game the next day. She hadn't been out of the house for really 2 to 3 weeks before the kyphoplasties. And this is, again, if you're not treating vertebral compression fractures, you'll see this every day in your practice. This is just what happens all the time. We did a DEXA scan. Her T-score was negative 3.5, and we then sent her to a hem-onc to maybe help with referral patterns for an infusion of an anti-resorptive medication. We made sure we started her on, we suggested to her PCP and made sure that he started her on calcium and vitamin D. We arranged for social services to come into the house and do a home audit and try to improve the home situation for safety with handholds, throw rugs, also kill people. Got her an elevated toilet seat, and we didn't. But again, we made sure social services did, and that can really help. We're not internists, And then we encouraged her to drink more milk. So she liked that. So in this one patient, we have kind of our own internal control on the kyphoplasty. And again, it worked great clinically. Bilateral access, 2 needles, procedure time 34 minutes, sedation time 45 minutes, fluoro time 4.5 minutes. And with a stability procedure, single access, 1 needle, faster procedure time, less sedation, and less fluoro. And this is actually fluoro time. And here, we're stepping back. That's not exposure to me. That's exposure to the patient. With a stability, you're stepping way back from the patient, and you've got your monitors down here at the end of the bed or even farther. So my fluoro exposure, I'm sure, was even a bigger differential than that. So, those are all really reasonable, but I kind of like the one on the right. So thank you.